Good afternoon, everyone.
Behavioral and emotional problems in children with neurodevelopmental disorders. So, which are the neurodevelopmental disorders? Disability disorder, SLD, communication disorders. What is the core feature? Core feature is early onset with developmental lag or deviation. Now, why are behavioral and emotional problems common? We need to understand that why behavioral issues most commonly occur in such kind of patients. Key contributing factors are communication difficulties. Because of their lack in the cognitive development, speech, other aspects, they are finding it difficult how to communicate their problems. Sensory processing issues, executive dysfunction, cognitive limitations, environmental mismatch. Sometimes we are not lacking environment, but we are able to verbalize, but our patients are not able to verbalize. So ultimately, what is the result is behavior is the communication. So in such patient, behavior is a part of communication, which has a common behavioral and emotional presentation. First is behavioral. So most of the patients we know that how they present, they are aggressively behaving. Relatives are telling that બહુ મારે છે જેને જોઈએ એને પથરા ઉપાડીને ફેંકી દે છે મારે છે અથવા તો aggression in the form of beating self or destruction. Yes. Hyperactivity, एक जगह शांतिથી બેસતો જ નથી. Then tantrums, self-injury in the form of sometimes biting self or banging head, opposing and argumentative behavior in the children who are getting elder, and emotional issues in the form of anxiety, irritability, low mood, emotional dysregulation, as well as fearfulness. The important thing is behavior may be common, but the cause may be different. So same behavior does not equal to same cause. Cause might be different, but they are having limitation of the communication. So they might behave in the same way, but the cause may be different. So how we go for psychiatric assessment? It is a structured approach. First is developmental context. So as Dr. Neelam said, that what is expected for this developmental age. So first we assess for that thing, at particular age, what actual behavior or what cognitive development, what practical domain achievement is expected. If child is meeting that thing, then we go for other thing. Otherwise, we go for neurodevelopmental disorder. Then there is the ABC analysis. First is antecedent. So which are the things which are leading to such kind of behavior? Then we assess for the behaviors. So which kind of behaviors are observed? And the third is consequences. What after the behavior happens? Please rule out medical causes. Every time we have to rule out, because even during the normal age, like at 2 years, at 3 years, at 5 years, children are not having that proper way of communication. So we have to rule out. Is there any pain? Is there any sleep related issues? Is there any post-ictal behavioral issues? Are there any GI issues, etc.? Because whenever there is GI issue, you might have seen, like I would like to ask that irritability is the most common thing that you see when there is a GI issue, right? When there is pain, patient becomes like they are irritated, they are crying. So we are not able to see because they are not able to speak. They always suggest through their behaviors. Then we have to screen for comorbidity. One thing we need to remember that neurodevelopmental disorders are not the one they are coming with the single diagnosis. It is not just every time that is intellectual disability is just intellectual disability. Autism spectrum disorder, then it is not just only autism spectrum disorder. Sometimes they are overlapping with other diagnoses like ADHD and autism, like social anxiety and autism. So we need to screen for those comorbidities also. And the third is family and school dynamics. That is also we need to assess. Like these are the overlapping symptoms of social anxiety and autism. Like kid who is having social anxiety, he will also not maintain gaze, like they will not maintain eye contact. But And autistic patients will also do not maintain eye contact. So we need to associate with other symptoms and then we have to diagnose that. Like in social anxiety and autism, there are overlapping symptoms of discomfort starting conversation, discomfort with parties, difficulty interacting with strangers, social withdrawal, social avoidance, and they do not like unexpected changes, sudden changes. Similarly, there is overlap between the symptoms of ADHD and autism. So we have to sometimes look for the comorbidities. That just patient is hyperactive, that doesn't mean that he is having ADHD only. So we have to see for the overlapping symptoms. Clues to comorbidities, like change from the baseline. Sometimes some of the behaviors are not visible since earlier, but over a period of time they changes. So there is a baseline thing. If there is a change in the behavior since last few days or few months, that is visible. So we have to assess for that. That is available with the patient, parents, that when we ask for history taking one, that we think we get that thing. New onset of behavior. Any behavior across settings. कुछ behaviors ऐसे होते हैं जो कुछ ही स्पेसिफिक जगह पे होते हैं. जैसे स्कूल में भी जा तो वहां पे ही इश्यू है, कहीं और नहीं हो रहा. जब गैदरिंग रहता है, पेरेंट्स सब कुछ लोग मिलते हैं, तब ज्यादा होता है. जब हम घर में सिर्फ फैमिली मेंबर्स होते हैं तो कोई प्रॉब्लम नहीं होती. तो such kind of behaviors should also be seen. Associated emotional distress, that also be considered. Example is like repetitive behavior may suggest autism, but repetitive behavior when associated with fear or distress, it is suggestive of OCD. Management principles, it is a stepwise and multimodal. The first step is psycho-education. It is the most important thing that we can do. First is normalize caregiver distress. We can understand the caregivers of the children with neurodevelopmental disorder. अगर हम as a parents हमारे बच्चों को देखें तो क्या लगता है? If they are having any neurodevelopmental disorder, तो हमें क्या लगेगा? That we need to see कि उनका जो distress है, उनके बच्चों के लिए, that we have to validate. उनको समझना जरूरी है, उनके लिए वो normalize करना जरूरी है. वो कितना distress face करते हैं. So first of all, जो उनको validation चाहिए. Yes, we understand that you are going through a very much struggle कि आप ऐसे बच्चों को raise कर रहे हैं जिनके लिए deal करना, जिनके साथ that is difficult. तो सबसे पहली चीज तो यही रहती है कि हम उनको validate करना चाहिए. Yes, we understand you. We have to empathize with them. And the second thing is explain to them that why such kind of behaviors are occurring. Then environmental modification, like structure, predictability, visual schedules, that we have to see. For autism patients, they do not like changes. So sudden change in their environment, like a few patients come to us, then अभी घर shift किया है, तो अभी नए घर में shift होना हमारे लिए difficult हो सकता है. Then what about autistic patients? They like their usual routine. So when there is a change in their usual routine, they're showing their tantrums and behaviors only, right? Third is behavioral interventions. Behavioral interventions have many of the things I can enlist over here. मैंने अभी 2 या 3 ही दिखाए. One is the positive reinforcement, and the second is parent management training. Then emotional regulation strategies like naming emotions. When they are growing up, उनको सिखाना है कि अगर अभी जो ये आपको feel हो रहा है, तो this is this emotion. Like अभी जो करो तो आप गुस्सा करो, इसे हम गुस्सा बोलते हैं. This is what we call sadness. So this is like naming emotions and sensory regulation. Medications are the last thing to approach. Like it is only required as and when needed. We do not start medications in each and every patient. We have to just target the symptom, not the diagnosis. All are the neurodevelopmental disorders. They are having some behavioral issues, emotional problems. But the most important thing is their family training, their parents training, and वो कैसे deal करते हैं अपने बच्चों के साथ, वो कितना समझते हैं. When they understand the child, they can manage their behaviors. And in that case, no medications are required. So we have to understand when behaviors are extremely out of control, then and then we require medications in the form of antipsychotics and mood stabilizers. And for that case also, we have to start low, go slow. That is, start with the low dose and gradually increase the dose as and when required, not otherwise. What parents can expect in their behavior therapy? Like in behavior therapy, Parents are sent to a child psychologist. They are being guided. Under guidance, वो sessions लेते हैं. Mainly 8 to 16 sessions are there. They teach parents कि आपको घर पे कैसे behave करना है, कहाँ कौन सा area है जहाँ पे आपको work करना है. Because child is staying most of the time with their parents only. So basic जो इसमें work रहता है, वो parents का ज़्यादा रहता है. Family involvement maximum चाहिए होता है. It is not like कि session में किसी psychologist ने बच्चे को सिखा दिया. No. इट इज एक बार सिखा दिया, पेरेंट्स को ये सिखाया कि आपको भी ये चेंज लाना है, मैं आपको सिखा रही हूँ, घर जाके ये आपको रिपीट करना है. देन इट वर्क्स, दैट लीड्स टू रिजल्ट्स. Between the sessions, parents practice using their skills they have learned from the therapist, and the therapist regularly मिलते रहते हैं, उनको बताते हैं कि ये बिहेवियर में इतना चेंज है, ये आपको और मॉडिफाई करने की जरूरत है. तो बेसिकली जो थेरेपी रहती है वो इस तरह से होती है. इट इज नॉट लाइक अदर साइकियाट्रिक डिसऑर्डर्स के जिसमें आए थेरेपिस्ट से काउंसलिंग लिया और हम घर चले गए. नो, इसमें पेरेंट्स को सबसे ज्यादा वर्क करना रहता है. रोल ऑफ द साइकियाट्रिस्ट, first of all, it is a diagnostic clarity. Sometimes the symptoms which are visible may lead to the thing that कुछ uncover हो रहा है, तो वो psychiatric diagnosis है, जो comorbidities है, we should not miss. Then identify the comorbidities, judicious use of medications, family support and guidance, and team coordination. It is not only the work of psychiatrist, but it works along with, in this case, neurodevelopmental disorders, psychiatrist, clinical psychologist, parents, kid, all work together to make it happen. I'm just showing up your case. That is 8-year-old boy with diagnosis of autism. Now, aggression in school. What would you like to assess? I'm asking to residents only. Okay.
It's setting.
Setting is already said that boy is becoming aggressive at school only. Yes, because school is the thing where social gathering is there. Autistic children do not like social gathering. So there might be sensory overload, and which might be leading to anxiety. So this should be our assessment. And ultimately the intervention is parent training plus classroom modification. And that will lead to reduced aggression. So in such case, there is no requirement of any medication to reduce the aggression. So treat the cause and not the label. That just baby is having autism, so we have to treat that. No, we cannot treat autism at all. एक साथ हम पूरा autism correct नहीं कर सकते. But these are the minor behaviors which we have to correct. So key take-home messages: behavior is a form of communication. Always assess developmentally. Look for comorbidities, non-pharmacological interventions first, and family support is central. When behavior is understood developmentally and emotionally, management becomes human, rational, and effective. Thank you.